Let's move on now to hear from Dr. Blair Thedinger, who's the Director of Clinical Education at CARE Health Center in Kansas City, Missouri. Blair?
Well, thanks everybody for inviting me to come speak. I'm joining you from Kansas City, Missouri. For those who are not familiar, it's a city of fountains, and of course we are the home of the undefeated Kansas City Chiefs, who are now 9-0 for the season. So I'm coming to you from the Kansas City CARE Health Center. We're a federally qualified health center, so there's a little bit of a different perspective than the other speakers who are more part of like a health system or hospital. We are an outpatient community health center. We have several different clinics, or a network of clinics through the Kansas City region, and one of several FQHCs in the Kansas City area. So I joined Kansas City CARE, which is also a Ryan White clinic. So I joined as a primary care doctor interested in treatment of HIV. And many of our patients were co-infected with hepatitis C. But then we also saw that we had a large population of patients who were just hepatitis C without HIV co-infection. And so we started a really more aggressive, active hepatitis C treatment program in 2013. And we were part of some clinical trials as well around hepatitis C drug development. So since that time, we've seen about 1,500 patients for hepatitis C who have been treated, and we have SVRs on most of those patients. We are a team, myself, a nurse, and a medical assistant. And that nurse position has been grant funded since the 2013 time. So that's really what has allowed us to kind of have a program. So, we do Hep C testing with rapid Hep C tests in our clinic for patients. We have also had grant funding for that. We also have a needle exchange on site. So we're doing the rapid Hep C testings at the needle exchange. And then over time, and that's really what I'm going to be talking about today, we've developed some partnerships with outside organizations and really trying to get our staff to go there to do rapid hepatitis C testing, or to actually give them kits so that their staff can do that. And the great thing about us is we've been able to treat patients with or without a payer source. So, Missouri was not a Medicaid expansion state until just more recently here, and Kansas remains not a Medicaid expansion state. So I think for the folks on the coast who maybe had immediate Medicaid expansion, we've been left in a difficult situation where a lot of the patients remain without health insurance. So we've relied on the generosity of the patient assistance programs, and that's where the medical assistant really comes in to help navigate patients through those patient assistance programs and the paperwork needed. But we've been really successful with those, both with Gilead and AbbVie and those partners in getting those medicines. We also have referral relationships with GI specialists for patients who come in with decompensated cirrhosis, and we are lucky to have 2 liver transplant centers in the city. So we can go to the next slide here. So as I said, we were doing our thing. We were treating hepatitis C, but seeing that the world of hepatitis C certainly expands beyond the patients who show up at our door. So we made some partnerships with the Office of Viral Hepatitis through the Missouri Department of Health Senior Services has their own hepatitis C elimination for the state of Missouri plan. And kind of coming off working with them, we decided to form the Kansas City Hepatitis C Task Force. And it was our health center, the KC CARE Health Center, along with another network of FQHCs called SWOPE Health. And there's a real champion of that, Rachel Nelson, who's a provider there who's been giving hepatitis C care now for years, and has treated many hundreds of patients and does a lot of outreach herself and has a team that's working on that. And then we're lucky to have a champion as well as the head of our Kansas City Health Department. And so Dr. Ben Grin was also highly interested in this. And the 3 of us really put together this task force, invited some of our colleagues and friends. You can go to the next slide. What we were looking for is, this just kind of shows who we are. We can go to the next slide here. What we're trying to put together was people from the state of Missouri, the Department of Health Senior Services, the Office of Viral Hepatitis. We have our city level folks from the Public Health Department. And then we have Rachel and I, FQHCs, and we've brought in the other representatives from the other FQHCs. We have a great representative from our public hospital. So we have one public hospital, University Health, was formerly called Truman Health, in Kansas City, Missouri, and we have a GI doctor there who is a great partner. And then the real bulk of the coalition is addiction treatment centers, sober living houses, homeless service organization, methadone treatment clinics, and staff from the Casey Care Needle Exchange. Basically, locations where we want to be testing people and doing outreach and doing Hep C education. And so it's really trying to get all those people together in a room, get people face to face, so that the people from the service organizations know who the people from the community health centers are. So you're not just sending off a fax or calling a number, you really know who you're talking to, and you get to meet them and talk to them. And so when we're trying to get patients to where they need to be seen, we have those relationships and that collaboration. Okay, we can go to the next slide. The stated purpose of the Elimination Task Force for the city was to reduce or eliminate hepatitis C, and we're going to be doing so by the collaboration I just talked about, by community outreach, and spreading education and awareness. And you can see our statement over there. Okay, you can go to the next slide here. I wanted to just say what I did not say was one of our members, really, and a key member, is Missouri Medicaid. So two things happened that just totally changed the game for hepatitis C treatment in the state of Missouri. And I'm hopeful that that's also going to be occurring in the state of Kansas soon. You know, after the introduction of DAAs, Missouri was not necessarily an early adopter of coverage for those, and there was actually quite a few barriers to getting treatment. So we had to do sobriety testing. We had to do and repeatedly for months. We had to wait until patients had F3 or F4 in order to access the treatment. And these were all things, of course, that we were concerned about. There's was initially maybe a little bit more adversarial relationship between the public payer and the providers. But something wonderful happened. The Missouri Medicaid, MoHealthNet, adopted a stance where they would allow coverage of Mavorite. And not only that, they allow without a prior authorization. And they took away all the fibrosis and sobriety requirements. And then they went further and became a real partner. And they are part of the Eliminate Hepatitis C coalition on this state and local level. They have their own initiative to identify Missouri Medicaid patients who have hepatitis C who have not been treated, and to share that information to providers. So, and we're really now close with the pharmacy benefit manager from the state of Missouri, and we've had a great relationship, and they've just been really proactive in trying to get patients with hepatitis C treated. So the tactics the coalition is using is the collaboration between the community health centers and the substance abuse treatment centers and homeless service centers. Linking people to care, so having a real direct phone number access from the people who are doing testing at those sites to our nurses, our nurse coordinators. We have done some focus on provider development, so there is a hepatitis C echo in the state of Missouri, and there are some other training opportunities. We're trying to both do that simultaneously. I think John Scott, the other provider, was talking about echo. We're definitely trying to increase the number of primary care doctors who are comfortable treating hepatitis C. At the same time, you know, we have a lot of areas of the state which would be considered treatment deserts. I would say many areas of the state, a patient would be unable to access treatment. So we do have a network of primary care FQHCs we're working with, but we're also integrating or working on some telehealth options for those patients in those areas of the state. So we can go to the next slide here. So, okay, this was just an example meeting agenda. We can just go to the next slide there. So on to the telemedicine collaboration. So The Missouri Department of Health Senior Services was actually helping identify hepatitis C cases through the viral hepatitis C office there at some expanded outreach testing events and some collaborative testing with some substance abuse treatment centers. Some of these areas are in rural locations, and we didn't have any providers there who were able or willing to treat hepatitis C. And so the folks from the state and myself initially got together with a plan to offer telemedicine. And that has now kind of expanded into other providers besides myself doing it, and a new partnership with the Department of Corrections. But we can just go to the next slide, and I'll just kind of go through some of the nuts and bolts of, what this looks like for us. Their partnerships through DHSS actually has the patients who test positive. Initially, the staff at the state, which is basically state health department, are giving patients our information, and so patients then have the responsibility to connect to us, and we give them the direct phone number of our hepatitis C nurse, and that worked. Some patients definitely reached out to us, but we would get, we would anticipate calls from people. And we wouldn't necessarily always get that outreach. What we really wanted was, we wanted to get the patient's health information, their contact information, and be able to reach out directly to them. And so we created a MOU with DHSS to be able to access that patient data and to contact patients ourselves. And so what we can do is we can do a really directed outreach to the people. We then register them as patients at KC Care. We get some labs through LabCorp or Quest, sometimes using local hospitals. We prefer to use, Quest Diagnostics or LabCorp whenever possible there. And the nurse and MA obtain the results. They give them to provider, myself, to review. And once we have that, we make a telehealth appointment. And we can go to the next slide. And we conduct the telehealth appointments, talk about comorbidities, other medicines they might be on, guidance on treatment. And then what we've done is we initially were just trying to prescribe the treatment to local pharmacies. It's worked out much better to send it to a specialty pharmacy that we collaborate with and then have them mail the medicines just directly to the patients. And then from there, the nurse and MA are confirming the patients have received the medicine. They mark the start date. They're doing phone call follow-ups at 4 weeks at end of treatment. And then we get the nurse to place the order for the hepatitis C viral load for the SVR, the test of cure, 12 weeks after the last day of treatment that they've reported to us. We can go to the next slide there. So this is our future goals, but we've already actually launched into some of this. So we have expanded into Kansas. We have a great partnership with Kansas Department of Health and Environment. We have some really excited staff there that is sending us patients for telehealth treatment of hepatitis C. As I mentioned, Missouri is now able to send us the patient information directly, and we're able to outreach to them. There's an organization called the Hep C Alliance in Missouri, which is helping with outreach testing, but also helping get some of those follow-up labs on patients who remain uninsured. We do have Medicaid expansion, but we do still have patients who are uninsured, and so they're pretty great about helping link people to care, link people to the labs they need for their workups to get the care. And then what we really want, and what is now happening, is we want partnerships with our county jail, which is still in development, but then also Missouri Department of Correction, which has really taken off. So the people at the state, the Department of Health Senior Services, has made some great connections with the Department of Corrections. And now inmates before release are being signed up for Medicaid. And when they come out, we are able to get the records from the workup. Now, I'll say there's two ways that this happens. So sometimes people go into the Missouri Department of Corrections, and of course they receive hepatitis C treatment because they're in there long enough to get the treatment. But you got to be in longer than 8 or 12 weeks to get the treatment, because there's you don't necessarily see the provider immediately. They do their own workup. That takes a while to get back. And then you got to get back into them, and then they got to prescribe the treatment. So a lot of people go in for relatively short stints for drug violations, for probation violations. and they're really not going to be offered treatment. They may get some of the workup done and have the lab work done, though. And we really need to link them to care right after. But a lot of people leaving Missouri Department of Corrections are not going to an area where they have access to a doctor to treat hepatitis C. So the folks at the state level are getting their information. They're getting signed up for Medicaid, and then they're getting immediately transitioned into doing a telehealth visit. We already have their labs often have their labs from the Missouri Department of Corrections. And so we just go right into prescribing them treatment and getting them onto treatment and following them through that care. And so that's just been an excellent thing that's been happening recently. And we anticipate a lot more referrals coming our way through that work. Okay, next slide there. So that wraps up what we're doing in Kansas City, Missouri. And I just want to say a big thank you to all the collaborative partners at the Kansas City Department of Health, the Missouri Department of Senior Health and Senior Services, and then Swope Health and Rachel and all the work she's doing over there. So we have a great group of people working on this problem in Kansas City and the state of Missouri. Thank you again for inviting me.
No, thank you very much. It really shows the power of coalition building. That's why coalition is in our name, just recognizing that you really have to bring different stakeholders to the table to really get the different levels of capacity that's needed to expand access in the way that you've described. Just had a few questions for you. In regards to the coalition, so who's responsible for convening it? Is it CARE Kansas City, or is it the state or local health department, or how does that actually work? And what's the frequency of you getting together to?
Yeah, so we've gotten together, I'd say a little less frequent than quarterly, and it's Rachel and myself and Ben Grin who have been convening the meetings. We don't have any kind of anyone specifically assigned the administrative duties of managing the coalition, and I would love to see that emerge one day. But of course, so there's really not any like particular funded time carved out of anybody. So this is just sort of an extra effort that people are doing to try to get together and collaborate. But luckily, the time I have spent on it is something that the FQHC supports, and I know that the other FQHCs involved have supported their staff members doing it.
No, your leadership has been critical. That's plain to see. I also had a few questions just about the various aspects of the program. First of all, John Scott mentioned the subscription model for purchasing HCV medications to lower the cost per patient treated of HCV therapy. And maybe you mentioned that and I missed it, but does Missouri have that same financial relationship with a pharmaceutical company?
Yeah, something happened. So Maverick came out, and that was the game changer because I can just share that there was some even legal battles I was involved with of trying to force Missouri Medicaid to cover, and then everything just kind of turned on a dime when Maverick came out. It was at a lower price, and then there was some negotiation that occurred between Missouri Medicaid and Maverick that just totally changed the game, between AbbVie and Medicaid, that just totally changed the game. I think that they just found the right price, that Missouri Medicaid felt like this wasn't going to bankrupt them, that they could afford to treat. And then once they did, to their credit, they just took a really aggressive stance on trying to get the treatment out there. And just the difference between having the sobriety requirements, and this was monthly for 3 months. I had to urine drug screens and a blood alcohol level, and waiting of course fibrosis requirements F3 F4 to absolutely no requirements and no PA for treatment. I mean, it was a stark night and day change, and it just really totally made the difference for our treatment program. And that all occurred prior to Medicaid expansion. So many of my patients still were just totally uninsured, and we were relying on patient assistance programs. that happened, and then Medicaid expansion happened, and now I have, most of my patients on Missouri Medicaid, and so they can access the treatment with just really no barriers.
So PA is prior authorization.
Yeah.
So it's great to hear that that's been dropped as well. So it sounds like that there are absolutely no restrictions any longer.
Yes.
That's really fantastic. Um, your telehealth approach, I'm going to cycle back over to John to get his thoughts about this as well, but your telehealth approach is very, interesting to me. It looks like you have the nurse follow up about 4 weeks after the start of treatment. Does the patient get the full 2 or 3 month prescription right up front, or do they have to go back for monthly refills?
Yeah, that's a great question. And luckily, Missouri Medicaid has made the commitment now that they give 8 weeks of medicine all at once. I am a big fan of that. Especially with the bulky Mavered boxes, I just think they're hard to lose because they're just, big old boxes of medicine. And the Now, not all sometimes people have other insurance. And so that is not the case that they're going to get all 8 weeks at once. But with Missouri Medicaid, they're going to get all 8 weeks at once, and that it really does make a difference. And it's mailed to their home or to where they're staying. We've had to negotiate and kind of work with some of the sober living houses or the transition living communities people are leaving incarceration and going to stay at, but they've been able to receive medicines at some of those places with a little bit of just a conversation with the right people.